Now in its 16th year, Campus Safety's Director of the Year program recognizes K-12 higher ed and hospital police chiefs, security directors, emergency managers, or heads of security and public safety who demonstrate outstanding leadership skills, ingenuity, and selflessness. We name the winner for each sector at one of our campus safety conferences. The nomination materials we receive are full of impressive accomplishments and collaborations. We briefly outline these achievements on our website, but wanted to further honor the nominees and their hard work by conducting interviews where they can elaborate on some of these successes. In these interviews, finalists share some of their challenges and subsequent solutions they've implemented. We hope campuses that may be considering similar endeavors find value and guidance in these discussions.
One of this year's finalists is William Adcox, Chief of Police for the University of Texas at Houston Police Department. In our discussion, Adcox shared how switching to a combined protection model and creating a shared purpose council resulted in improved performance and outcomes for both the organizations he serves and the surrounding community. He also shares an anecdote on the importance of de-escalation training and practitioners reporting incidents of hospital workplace violence. Thanks for listening.
Today, I'm here with William Adcox, Vice President, Chief of Police, and Chief Security Officer for the University of Texas MD Anderson Cancer Center and the University of Texas Health Science Center at Houston. And Chief Adcox, can you briefly discuss, reading over your Director of the Year nomination materials, there was obviously a lot of impressive content, but one question that I'd like to ask is, can you briefly discuss the department's combined protection model and why it was implemented?
Certainly. First off, thank you for the opportunity to interview with you. I'm very honored to have this opportunity. Our combined protection model is the collective work that's being done by our division. And the way it works is that we have 5 service levels, 5 service lines, and it's how they all integrate together and work within the institutions that we serve. And it's how we get to our shared purpose of prevention, protection, and preparedness, with what we call a continuous performance improvement loop. And basically what it really does is it allows us to show how these different intricate parts work together at any given time in order to provide the services and the protections to our campus.
Okay. And now your nomination says the CPM has resulted in improved performance and outcomes for both your organizations and also the community. And it also mentions specifically how data visualization tools that you have helped identify programs or processes that show low return and are therefore recalibrated or retired completely. Can you give an example and also how this strategic reduction helped minimize negative impacts or increased efficiencies?
Certainly. So all of our leadership in our 5 service areas, they put together data visualization. So they each have a series of dashboards that they monitor, and they monitor our performance metrics and really it's everything that you can think of, all the way to near misses. And the way that it works is that we actually get together and we look at the different areas and we actually evaluate the different areas on their performance and where it's going. And we have recalibrated, we continue to recalibrate. That's that continuous performance improvement loop. So we had just on the police side, we had a gain unit at one time. Well, because as we went through the time, actually gains have not been the problem that other types of crimes have had. So we've recalibrated out of the gains to a different definition, which expanded their role so that we're getting more productivity out of this particular group. We also have looked at our like, for example, our a lot of people call them guards. We call them, PSOs. And our PSOs, we went and looked at it, and we actually developed a job class so that there's a career ladder. So you have a PSO, you have a senior PSO, you have a supervisor. Now we have a manager, and then we have a director. And so someone could come into the organization and work your way all the way up. And we did that so that we could then across those lines have additional responsibilities so that we could evaluate, we could promote, we could get better efficiencies out of this group So that's just another example. Another example is that in our technical services area, we have a very small group of what basically a lot of people call break fix type people. And certainly with a system as large as ours, we just weren't effective. And so we went back and looked at it, recalibrated it, and developed them into where they might be available for the emergency fixes or things that have to be done on the spot. But they're more in line now with how we use third parties to come out and assist us in these different break fix situations. So it really has helped us to really go a long ways with where we're going. And we look at these charts through our shared purpose council, and we evaluate it. And in fact, these particular dashboards are open and available to all of our personnel across those service lines. And so that you can actually see how those different service lines integrate with each other through the data visualization. And it's been very, very helpful for us.
Now that's a good segue, because you mentioned the shared purpose council, which was going to be my next question. Can you elaborate a little bit on what it does, who's on the council, and also some successes since its creation?
Certainly. First of all, let me explain the shared purpose council a little bit. In the medical arena, there's a thing called quality assurance and performance improvement. They call it QAPI. And in policing, there's a thing called CompStat, which is computerized statistics to look at what's going on and looking at your crime rates. And for us, this was a way that we could take our combined protection model and by using data visualization and the metrics is to be able to then evaluate this from a leadership standpoint. So on a bi-monthly basis, we'll pull the groups together, and then each of those service levels service areas have to come in and discuss. So they'll bring up their dashboards. They'll go over where they're at. And so we have the dashboards are where there's a performance needle. So they either be in the green, the yellow, or the red. And so they have to explain to us where they're at and where they're going and what are some of the causation factors. And then it also allows them to ask for help if they need help. If they get into an area where they need some help, that's how we can kind of help across those different service levels at any given time. So we come together bi-weekly. The leaders of those groups give their presentation. We ask them what they need. They tell us what they need, and we ask them what's their plans for moving forward. In order, if there is a particular area that's in the red, that's what's your plans for moving forward. But it's also an opportunity for the executive team to ask those questions, to ask some of those tough questions. And so we look for patterns. We look for some shortcomings. We also look for the successes. We also want to make sure that we're celebrating those successes. So while we have a preoccupation with failure, like any highly reliable organization does, we'll look at that. But we also want to make sure that we're recognizing the great performance. So during the Shared Purpose Council, we'll also do our safety heroes. We'll also point out those that have gone beyond the expectations, who has done an exceptional job at all levels, whether it's a public safety or PSO, or whether it's a manager, a leader, a technician, one of our threat analysts, whatever it might be. We'll make sure we do that. So one of our service lines is threat management, is the area which we now call workplace violence. And in there we talk a lot about these particular cases that come and grow. And so there's a lot of connectivity with those with our security services, because if we have a safety plan in place, we have to make sure that all of the different service lines are coming into place. So you have a safety plan in place for the individual that may be under threat. You have a management plan in place for your institution as a whole and other employees. And then you have your threat plan, which is what are you going to do to reduce that threat or neutralize it? And so those pieces and parts have to come together. And when you're talking in your shared purpose council, you're able to discuss these and look at what parts and pieces you need from the combined protection model in order to make that happen. One of the things I will say, and it's very important to realize, is if you look at our model, we put it up visually, it looks like it's linear, it goes across, but it's not. It's more to think of it more like a spider web, because you might have a call that comes in, and there's different pieces and parts will be getting engaged at different times. So while you might look at your average organization, it might be in the middle piece. We have a lot on the prevention side, and we have a lot on the aftermath, and what we're doing to pick up the pieces and then to develop those target hardening pieces. And so all those parts and pieces are moving at any given time. So that it's integrated more like a spider web. But although in order to look at it, it'll show that the 5 service lines are crossed to the shared purpose model.
And now, when did you implement this council? How long has it been around for?
Our shared purpose council has been around probably for just over a year.
Okay.
The first thing we did was developed our combined protection model. And then as we brought the right expertise on board, we started developing some of the analysis capability, and we started looking at, what are the real key metrics. We did some benchmarking. We looked across the industries, and then we looked at how these parts and pieces come together. The most recent change that we had actually was taking our service line that we had that was threat management, and we recalibrated that to become what we call as workplace violence. We did that because with the new Joint Commission standards, the institutions have appointed us as the stewards for workplace violence at both institutions. And in doing that, threat management is obviously a big piece of that. So when we have our behavioral intervention team at both institutions, each one has a team. We actually have a threat management team inside the police department in the investigative units that works hand in hand with the behavioral intervention team. So as we're meeting those particular standards, and believe it or not, each academic, medical, and then hospitals with the QAPI, they have a major QAPI thing. And if you ever attend one of those, if they're talking about infections and medication errors, they talk about different things that they have to build on for quality assurance and even performance improvement. I don't know if other security or police departments have done it, but we actually went to QAPI, to the institution's QAPI, and we're actually part of their program. And so our workplace violence is actually part of that QAPI. And right now, workplace violence has now gone up on the risk registry, and it's a separate piece in and of itself. So we've had a lot of really good movement at the institution level to get others to be involved, because we believe very deeply that safety and security is not a department's responsibility. It's every employee, every visit, anybody that's here. We're responsible for each other. We're responsible for making sure that we have a safe place. And that's really the premise behind the combined protection model, is how does everyone work together?
I spoke to another practitioner recently, and she was saying how she was hopeful that right now, obviously, workplace violence in hospitals is through the roof, but she was hopeful that with the new guidelines, you'll soon start seeing a difference in numbers of incidents and de-escalation before it gets into a violent incident. So it'll be interesting to see how much of a difference those new guidelines make.
I would say that it's a journey. I would say that you cannot predict, but what you can do is you can look for the problems and the indicators, and also for the triggers. And those are the things you can pay close attention to. And she's absolutely right. Teaching your staff, employees, and everyone how to de-escalate, how to avoid a problem from the very beginning is very critical. But with the new standards, there's a tremendous amount of education and awareness that has to take place that has not taken place before, and a realization that getting abused or getting assaulted is not part of your job. A lot of people within the hospitals have thought, well, the patient's upset or they're hurting or something. So it's part of my job to take some abuse or to get kicked or whatever. And so you teach them that that's really not the issue. So what you're going to see, if the programs are working very well, is that the reported numbers of workplace violence are likely to go up.
Higher, yep.
But the quality of your assessment and your interventions that you take from there in order to de-escalate or to get the proper processes and procedures and systems in place will improve upon that. And so at some point it will level out to really what's going on, because we know that workplace violence in healthcare is tremendously underreported. The goal is to get it appropriately reported, and then to put the systems and processes in place that help to reduce those, and then actually to take care of them and to prevent them from the beginning. And so that's what we do. And if you look at some of ours, we've broken down the 4 typologies of violence. We've broken them down into like 1A, 1B, 1C. so that we can get it granular, so that we can really get engaged with the clinicians in particular, because the largest number that in most healthcare is going to be a patient on a caretaker, on a practitioner. So that's why, we break it down so it's a little bit more granular with a multi-discipline cross-functional team, which we call behavioral intervention team. In our case, it's either STOP or 2-STOP, depending on which institution. And you engage this team so that you can find out whether it's some sort of psychosis, or whether it's some sort of medication, or other, what's really driving this particular anger, or this particular violence, or what's going on. We do not have a prosecution model. We do not have an arrest model, and that's very important to point out. Our goal is always to get in front of something to prevent it, and if we can't, we're going to work really diligently to try to do our best to resolve it. It doesn't do anybody any good if you're just looking at putting an arrest on somebody, because by then, guess what? In order to make an arrest, something's already occurred, and that means we failed at our primary goal, which is to prevent something. We have to go to the secondary goal, which is to find out who committed the particular crime, and then bring justice to it. So it's very important that you get involved and you have the right people. So the police department, security police department here, our division, is involved in all the information and all of the different cases from the very beginning, even in the clinics. But that's just so that you have a holistic sharing of information, so that you get all the different parts and pieces and expertise, because everybody sees the world through a different lens. Our clinicians, our nurses, even our staff that's in our psychiatry, our staff that's in the administrative roles, our patient advocates, everybody sees it. Risk sees it differently, legal sees it differently. And if we don't have all those lenses looking at it, you really are not going to get the most robust and the richest solutions in place. And that's very, very critical. I'll give you an example. We had a case where a young patient was very ill and nearing end of life. And there was a threat involving with the parent, and one of the parent was suffering from some mental issues as a result. And it'd been very easily, you could have taken the parent out of the hospital, put him into an emergency detention, and had him away. But what would have happened is the child would have passed during that time, and the problems that would have caused this parent long term. So what we were able to do is, and we have a very proactive institution, was able to get us to be able to commit this individual within our own institution, so that she could be there with the child while getting treatment and getting the help that she needed at the levels that she needed. And so she was there with her child at the end of life, and it brought some closure to her. And she did not, she didn't carry on to what she was going to do before, as she went home to the rest of her family. And so those are the types of things that you can do when you have this holistic team and everybody is willing to solve a problem, and not look at a simple solution of getting somebody out of your institution, because that might be a short-term solution, but it may cause long-term problems.